Thank you very much, Marta. It's a pleasure to be joining you all today for this update. And can I first start by also congratulating Jo Martin and her team for the great award given last night for the pathology portal. I'm just going to share my screen with my talk now, which you should be able to see any minute. Okay, so I'm going to talk about very important topic that's become so important now going forwards in terms of healthcare across the UK, and that is workforce, and focusing on particularly the implications for education, given the theme of today's meeting. We're all aware of the current state of healthcare within the UK, especially within the NHS, and we're all aware of things like the waiting list, which continue to become more and more difficult. And the Health Foundation, who are a relatively independent group, published a prediction algorithm a couple of months ago, which suggested really that the waiting lists were likely to continue to rise through 2024, and only by the end of 24 will we see those lists begin to potentially slowly decrease. And they're quite clear in what they think are the sort of roots of why we're in this situation, and it's really about a decade of underinvestment across the NHS, and a failure in particular to address chronic staff shortages, and also those within social care as well. And if we think, we don't have the workforce to deal with what we need to do now, in the future, it's going to be even more demanding, because we know what the trends are across, population stats and demographics, with an increasing aging population, and all the illness and disease, especially cancer, that type of population brings. I'll come back to that later. It's not just about waiting lists, of course. It's about backlogs in other areas of healthcare. We all know about ambulance waits outside A&Es, slow patient pathways through the emergency department, and of course problems in primary care as well, with access to general practice, and indeed access to emergency ambulance pickups. All of these really all factoring in and bouncing off each other, and really highlighting that we are in quite a sort of desperate crisis across healthcare, really. So it's a great time to think about doing things differently. It's a great time to pick up the challenge of trying to change things for the better. And while it's very depressing, I think it's fair to say that in these types of situations, this is where little bits of effort can make a huge difference. So that really has to be our drive over the next few years. Inevitably, I'm going to talk about the NHS long-term workforce plan, published by NHS England for NHS England in June of this year, which many of you will be familiar with. We are, of course, a four-nation, within the UK, and there are other plans out there which are quite similar. With the Scottish plan, which is now more than a year old, again, less specific about funding and less specific about the overall timeline, but nevertheless focusing on very, very similar issues. And also in Wales, we had a workforce strategy which is now 3 years old, and again, a lot has happened in 3 years, so potentially, we will see that being updated as well. But clearly, the NHS long-term workforce plan has been pulled together, over quite a long period of time, and has the benefit of being fairly recent, and therefore reflective of the challenges that we're now facing post-pandemic, especially. Why do we need a plan? Well, as I said, we know we've got huge staff shortages now. Upwards of 122,000 vacancies across the NHS this year, and more than that within social care. And when we look to the future and the increasing demands that we're likely to see across healthcare, then that gap in staff shortages is likely to grow much, much wider. mentioned the aging population and the impact that has on morbidity and cancer, and that has particular relevance to pathology services, especially cellular pathology, which would, take the burden of the investigation and the monitoring of those illnesses. It's estimated that by the next 5 to 10 years, we will see massive increases in those over the age of 85, a 55% increase, which is a huge amount. So workforce plan is vitally important to have one. It's vitally important to look to see ways in which we can try and shorten that sort of gap that we see. It's a long-term plan. We can't just flick a switch, of course. So it's a 15-year plan. There is a lot of uncertainty around, things like funding of the plan. Clearly, the current government is not in a position to, align funding and promise funding beyond, their own term, but also beyond any spending cycle within government. So at the moment, the funding promised is fairly limited. We also have to think about feasibility, which we'll cover. Big question marks around whether there are enough people wanting to work within the new NHS, with the vastly increased number of workers, and also whether or not we have the capacity to educate them all, given the pressures that we have. And there are many other uncertainties around that as well, in terms of whether it's politically acceptable, and whether the Treasury itself actually sees it as a potentially feasible funding option. So I'll cover some of that going forwards. I'd just like to start just by referring to the GMC's recent report, which has come out in the last month or so, which is their sort of snapshot at the workforce. I would certainly refer you to have a look at this. It's quite a good document. It's probably as best as we'll get for this type of thing. The data is not perfect. It's not great. It's some of the information in it, to be honest, is maybe not accurate. I know that because when you look at the pathology stuff, there's clearly the numbers in it aren't necessarily matching the numbers that we certainly see, and also they're limited to focusing largely on headcount when they're talking about workforce. And while they acknowledge that whole-time equivalent output is more important, they clearly don't have access to that kind of data in order to make those observations. But there's a few trends that we can certainly pick up, from looking at the way in which the workforce has changed and is changing. We increasingly see a larger proportion of females within medicine, and also an increasing number of young doctors taking time out for whatever reason at the end of FY2. And also the increases that we've seen in new doctors, both coming into the country to work, but also in training, has come largely from overseas-based candidates. But the important thing is that they make this statement that even with the expansions of medical school places that we see within the workforce plan over the next 15 years, it's likely that we'll need to absolutely continue to attract skilled and experienced international medical graduates as well, and that there won't still be enough homegrown doctors being produced. If we look at some of the trends within that document, we continue to see an increasing proportion of the medical workforce being female, and we're now approaching across the UK a sort of 50-50 split, and that's really developed further since 2012. If you look at the right hand side there for pathology, we're pretty much approaching about a 50-50 split there. This, of course, is headcount. It's not whole-time equivalent, so those numbers may vary. And if we look at the proportion of gender across current medical schools, we see that it's roughly about 2/3 of medical students are female in most of the countries, with up to 75% in Northern Ireland. So certainly there is an increasing proportion of females within the workforce, as I've said, and you know, we're likely to see that continuing. But what we're also seeing across both males and females is an increased likelihood that doctors will want to work less than full time, that they will want to take career breaks, that they will not necessarily be keen to work the kind of long hours and conditions that their predecessors have. And that is an important thing to bring into the equation when we try to predict how many doctors we need to train, and indeed for all staff. Here's the latest sort of graph looking at that drift of FY2, and it's always been the case that, you know, a lot of doctors decide to take career breaks. Some of them go off overseas. Some of them enter locum positions or you know, non-training posts. But when you go fast forward 2, 3, 4 years, pretty much most of them have come back to enter specialist training, and that really drives up to about 90%. So there's no evidence at the moment that while doctors are not joining specialist training immediately after FY2, eventually, you know, they mostly come back. However, if you look at the left-hand side of this graph, you can see that, you know, going back to 2012, it was about 65% of doctors entered specialist training after FY2. That now has dropped in 2019-20 to roughly 30%. So that's a significant downward trend, and it remains to be seen, especially given current culture, current conditions and pay and so on, and all the issues around industrial action, whether all of them will come back and reach that 90% mark that we've seen in previous years. So there is a big question mark over that. The long-term workforce plan, of course, is now out there, and you know, it's vitally important that we all engage with it. It's vital that we support it and use it as the reference document, really, to direct us, both in terms of the college, in terms of those who train and educate, and also in terms of, you know, the way in which employers you know, employ their staff and seek to retain their staff. And also with any reforms that may come in to alter the way in which we deliver healthcare. And I'm going to deal with these one at a time. If we stick to, first of all, with training, clearly that's a big part of it. And the workforce plan really is about growing the workforce, up to 73% increase in the number of trained staff working across healthcare. And, you know, they're going to try and do that by expanding massively you know, the number of trainees across nursing, across medicine, and AHPs and so on. And for medical school alone, they're looking to double the number of places by 2031, from currently 7,500 up to 15,000 places, which is a massive increase and has huge implications for training capacity, universities, postgraduate, and so on. And so it's a huge thing to think about. It's not clear just how that's going to happen at the moment, but there's talk of both increasing the size of medical schools, but also potentially some new medical schools as well. They talk of apprenticeships, and looking at ways in which we can widen the access opportunities for those wanting to study medicine in particular. And well, I certainly would support that. It remains unclear just how that's going to work, and you know, again, big question marks over the training and over the educator side of it in terms of how it will fit in. And at the bottom there, big increases again across nurses, across AHPs, across scientists, and also, you know, groups like medical associates, you know, which have become a bit controversial at the moment, and I'll cover that briefly later. So training is a big part of it, and the message is massive increase that they want to try and bring in. in order to try and increase the number of doctors in particular, in order to ensure that we have enough to fill the vacancy gaps that exist at present, but also to fill those new jobs that will be needed to deal with the changing face of healthcare demand that we're likely to see in the coming years. Here's just a graph demonstrating some, the magnitude of the changes up to 2031 that the plan looks to try and bring in with a huge increase, doubling of medical school places on the left-hand side and a massive number of new nurses coming in. And there are various mechanisms that obviously will need to be addressed to try and ensure that that's a success. They sort of missed off largely clinical scientists and biomedical scientists within this plan, and we've certainly had discussions to ensure they're not forgotten about, and they're a vital part of the workforce within pathology as well, of course, and we need to ensure that those levels absolutely keep up with the sort of trends that we're going to likely to also see within those professional roles. Implications for training and education, of course, are huge, and it's estimated that educator capacity, training capacity, needs to increase by around 65%. There is some money available initially. The government have released 2.4 billion to be made available as extra money until 2029. But it remains uncertain at the moment just how that money is going to be used, and more importantly, how it's going to be allocated. There's still at the moment a reliance on overseas recruitment, and that will continue, for many, many years, because it's really the only way in which we can bring doctors in to work in the NHS at the moment, because there isn't a local supply. We've already, exhausted that, and until the new medical school numbers come in, the sort of bit of light at the end of the tunnel, of course, is that we did see an increase recently of medical students from 6,000 up to 7,500. And of course, they will be graduating in the next couple of years, and I should be able to work into the system to at least alleviate some of the gaps that we currently have. Of course, that's assuming that they want to continue to work in the NHS and that they will, enter specialist training, of course. It must also be noted, of course, that the increase that we saw in medical student numbers of, pretty much 25%, most of those places went to overseas candidates, we presume because they're lucrative income for universities. So it's a changing demographic amongst that group. We also need to look, of course, at extension of scope and competencies surrounding that. And that's very relevant to pathology and also slightly controversial, of course, with regards to the expanding role and scope for biomedical sciences and cellular pathology, for example, which the college has been working very closely with IBMS on for many years, and we're beginning to see that taking shape now. But the reality is we don't have enough pathologists, and we will never have enough pathologists. And so looking at ways in which we can work better as a team, share some of the workloads, share some of the scope where it's possible, and ensure that's done safely, then that will definitely continue to be an important part of how we provide pathology services going forwards. In other disciplines, of course, there is huge overlap of the Venn diagram when we look at the skills and scopes and roles of biomedical scientists, clinical scientists, and pathologists, and that clearly will continue. Across medicine, of course, we're seeing a lot of controversy at the moment around physician associates and so on, and that is certainly with foundation some of the concerns, and so there needs to be some thought around how those particular groups are regulated. In particular, we are fortunate in that the expansion of scope we're seeing across biomedical scientists is from a very well trained, motivated, and regulated population of pathology workforce that ensures that we have that covered. It's not just about training, though, and this is something we must remember. It's okay training, up to 15,000 medical students, but we've got to have jobs for them to go to. And while there are some vacancies within the system at the moment, it's clear that in the future we need a lot more posts and a lot more pathology posts in particular. And that is an area that we need to plug into, and we need to ensure that that happens. And the mechanisms for, sanctioning substantive posts is generally done locally within health boards, within health regions, within pathology networks. And that is where we need to ensure that that process is smooth and that the funding becomes available and that we make the case for that. And that's an important part going forwards. So training new students, training new doctors, training new pathologists is vital, but we need those new substantive posts in order to make it all worthwhile. The second pillar of this plan is around retention, and which has become just as important, especially in the short term, because while we wait for hopefully the big army of new pathology workforce to come into play, we've got to try and keep hold of the valuable members of staff that we currently have, and that's both in terms of those coming into the system, but also those at the other end of the system. And there is a danger that we see, especially with the pressures within the NHS at the moment, that we see more and more individuals retiring early or leaving for other roles. And I think we have to look at ways in which we can improve that. Clearly, the elephant in the room with this is pay and conditions. And with industrial action taking place just now, you can see how that's a big part of the reasoning, especially in junior doctors' terms, of reasons why they may or may not want to continue to work in the UK or indeed work in the NHS. And I think that is going to be a big factor going forward when we see what happens to those 70+% of FY2s who leave the NHS, or at least don't go into training posts. And that will be something we'll have to play out. But there's other things as well that we need to focus on. So the strategy needs to be wide, and we need to look at ways in which we can improve the notion of respect for doctors in particular, a compassionate workforce and a compassionate, NHS, and also aspects of things like ensuring there's equality and diversity and inclusivity in everything we do, and that is going to be vitally important, especially with the younger age group coming in, where these values are rightly, held up quite high. Of course, it's very difficult when your Secretary of State or ex-Secretary of State writes to NHS trusts suggesting that they immediately stop, employing anyone into these roles. So that's very much a mixed message coming from government that we absolutely need to argue against. Retirement and pension rules at the other end, of course, are big issues, and while there have been some improvements in those in terms of some of the crazy rules we've had to align to, especially those which limit doctors doing additional work when they have the time to do it. There's still a long way to go here, and we need to make it simpler and easier for individuals to retire and come back, but also a peri-retirement type approach where they can select what kind of work is most suited to them. So there's a lot of talk about this, and we may see this concept of consultant emeritus type roles, whereby post-retirement we can create an NHS bank of recently retired doctors, including pathologists, who can pick and choose what they do when they do it, and that way we can still use that fantastic expertise that we have. So that's retention. Reform is clearly something that is talked about a lot, but it's something that's very difficult to do and very, very slow to do. But it's something we absolutely have to look at, because we know that at this moment in time, the NHS isn't working. It's become very reactive. There's very little in the way of preventative medicine. That's really gone out the window in the last 5 years. And it's all about trying to cope with immediate care. And that's appropriate. Given the demands and the pressures that we currently have. But we need to think about ways in which we can shift things back. And obviously the workforce plan, in terms of increasing numbers, in terms of filling the sort of vacancy gaps, that's an important part of that, to be able to create that breathing space to focus on that. But we need to think of other things as well, and obviously upscaling various groups, and again looking at the sort of team approach and looking at the ways in which different groups across healthcare can deliver different skills and expand their roles. That is going to be important. So the importance of associate roles, AHPs, and in pathology, biomedical scientists, expanded roles to both dissection and reporting, where it's appropriate and where we can train and ensure those competencies are in place. They're going to have to be big parts of the equation. Other things like automation, especially pre-analytical stuff, that will speed up and give us more time to do the things we need to do. And of course, digital pathology is part of that, in terms of both the way in which we are able to make the system more efficient, but also share information and share workload across the UK is going to be vitally important as well. And we've got a long way to go there. Artificial intelligence might be a part of that, of course. At the moment, it's not really. There's a long way to go there. We need to get digital path in place for cell path, and we need to get functional LIMS systems in place as well for blood sciences to be able to take advantage of the potential of AI. But there's a lot of interest, certainly in government, about that. And we've had various meetings over the last month or so with them just to see about the possibility. But the message is clear. AI has got potential, but we need digital pathology to be rolled out everywhere in order to make that a reality. And also AI will alter the way we do things, make things more efficient, but AI will not replace pathologists. AI will just make it more easier for pathologists to do the more important things that they are highly skilled and highly experienced to bring about. So that's for the future. I'll refer you as well to this, which some of you may have seen, strangely published 3 months before the workforce plan, but very much aligned to it, and that is an educator workforce strategy. And there's some useful things in here, and it's clear that if we're going to have more trainees, we're going to need more educators. And also, if we've got more trainees, given the capacity, not just in terms of number of educators, but the capacity of our buildings, of our lecture theatres and so on, then we need new ways to deliver that. And with all these new trainees, not just in medicine, but in nursing and in AHPs and in associate roles, there is going to be huge competition for frontline clinical experience. And that is something that we have to manage in different ways, because there isn't the capacity to actually make that happen. Again, refer back to this ubiquitous 2.4 billion extra. Again, we'll wait and see how that's going to be used, but clearly a large part of that has to be used to expand both the sort of areas that we deliver education from and the ways in which we deliver it, and also the number of educators. And it's important that we build that capacity, the quality and the scope and the skills for delivering that new type of education. Is it feasible? I mean, it's quoted that with the new switch to all these new trainees, we will go from 1 in 9 to 1 in 6. Sorry, there's someone coming in my door. Sorry about that. The supply of trainees is also in question, and the educator workforce strategy and other groups have sort of highlighted this, and that the number of trainees coming in to healthcare may actually be limited within the UK, in the sense that when we look at the sort of birth rates across the decades, we are currently at a sort of peak at the moment for those that were born around just after the turn of the millennium, and but that sweet spot is going to drift away over the next 10 years, and so by the 2030s we will see less and less people around the age of 15 to 25 who may want to take up some of these trainee slots. So it's not guaranteed that we will have an endless queue of people around the block to actually take up some of these training posts. Competing interests is clearly a big part of this. As I mentioned, there's going to be huge competition for coal-face frontline clinical experience and training, and that is going to be interesting to see how that develops. But it's clear that we have to think out the box really and look at different ways in which we can deliver that. And things like the pathology portal, for pathology trainees is going to be vital going forwards, but also other media and other opportunities to look at all these things. What's the role of the college and those who are involved in education, from universities through to postgraduate education as well, and of course the sort of services that provide healthcare. Clearly, in order to make the case for more trainees, because it's not going to be automatic, it's not going to be guaranteed, we need better data on workforce currently, data on workforce trends, and of course data on workload in order to make that equation fit. And then also we need to use that information to make the case and make the argument, and we have to be robust about that. It's sort of remarkable that the mechanisms that decide pathology trainees and numbers of pathology trainees at the moment is not robust at all, and it's very much plucked out the air, and that is highly surprising to us. But nevertheless, we have to make sure that we can argue our case, and I think we can do that more robustly going forward if we improve the workforce data that we currently have and hold. And we can do that by sharing various sources, both from college, but also from across NHS England data and various other specialist groups. Substantive posts, as I've said, it's important that, for a Royal College that we try and provide the tools that allow local business cases to be developed in order to try and make the case for new substantive posts across the pathology networks and so on. And that's something that we will definitely be looking at in the coming years. There's a question mark of who do we train? And clearly within the educator strategy and within the workforce plan, there is the big push that with the expansion and training required over the next 10, 15 years and after that, then it won't be the case that pathologists will train pathologists and that's it. Pathologists will be training scientists, biomedical scientists, potentially nurses, and anyone else where it's relevant to exchange that knowledge. So it's important that we realise that education now is much wider. We work as a team, and therefore we have to train the team, and that really needs to be the appropriate way that we deal with things. Training methods we've talked about. It's not just about laboratory skills. For pathology, 17 disciplines across pathology, many of whom have increasing clinical roles, and we need to ensure that that is also taken care of. And not just about trainees, we need to train our consultants, especially with new skills and new tasks that may be required around metabolic areas that are expanding, but also clearly digital AI algorithms and AI itself, if and when that comes and if and when it's affordable. Training the trainers, of course, we need to ensure that that's in place with the projected expansion that we're going to need, and we're going to need to make sure that it's properly funded and people are given the proper time to actually do it. So this is where a big efforts in how we approach things like job plans is needed, and as a college certainly we will absolutely be looking at new ways in which we can support and provide the tools that allow individuals to ensure that they have the appropriate time allocation and other mechanisms in place that allow them to provide the education that's been asked of them. It's going to be highly competitive though, just to really finish on, and you know, there's clearly not enough money in the system at the moment. The 2.4 billion that's been promised over the next 5 years will not go far, and we have to be in a position across pathology to ensure we can compete with it. So that's long-term workforce plan. It's an NHS England plan. It's easy to be sceptical about it, of course, and you know, many have suggested that it's simply a vacuous political football that's just being kicked around to, on one hand, pretend that something's being done when in reality very little's being done, and also to set up the next government who that will be to be the fall guys who won't be able to deliver on it because it's unaffordable. You know, all those things have been said, but I think we've got to put that aside. We've got to engage with it, we've got to support it, and we've got to use it as the reference document to base what we do as a college and what we do as pathologists to both train, retain, and reform everything that we do. Thank you.